openness, and I'm going to try to keep my remarks to the 10 minutes that I ask everybody else to keep them to. The reason it's 10 minutes is because that's about half the day if we get all the way around the table. And that would give us another half of the day to have a free discussion about what we're talking about. And what we hope to bring away from this conference is some ideas that may help us solve some fundamental problem that we're facing in our culture and that is being faced in other places in the world, maybe under more dire conditions and under more unfortunate circumstances than we have here. And that is that our system of healthcare is often referred to as a money-driven system, but it's probably worse than that. All right? It's not only just stimulated and exists because people earn a living doing it at all kinds of levels. It's also creating a lot of death and a lot of injury on its own, without regard to the accidents that happen in life and the diseases that we are actually killing people using the medical care system that is chaotic and disorderly and inhumane. And the numbers are astounding. Now, I know you've read and seen the research that's been published and has been published for the last 20 years that shows that number of deaths is approaching 800,000 a year killed by people who practice medicine in hospitals, and that the number of injuries are like 8 million. So what we have is a system in which there are a lot of players, beginning with those who gather the patients together and collect their money and use it to pay for their medical care, to each of the partners provide some aspect of that medical care, some part of it. And in every case, everybody is presumably doing what they think is good, right, moral, and helpful. But when something is being done with those intentions, the right intention, but it's resulting in bad outcomes, then you get a government that is alarmed. And that's what's happening right now. It's sufficiently alarmed that in spite of the partisanship in this country between the parties, and they're supporting different programs, they still passed a healthcare law that is saying to us, in particular to the medical profession, that you must become accountable. You must tell us what you're doing, and you must tell it in detail. And if you do, that we will then attribute to you patients that we pay the claims for, that we pay the bill for. And we have presumed that the employers will follow suit, that they will look at your reports and say to themselves, these are the people that are paying attention and can do something, and others will not be able to. Now what that's telling you is that every person that is a player in the healthcare business and in the healthcare services is being watched. And they're being watched because the amount of money being spent for it is excessive, in the sense that if you compare the money in the United States spent per person per year for healthcare, which is about $8,000, with that being spent in other countries that have better health outcomes than we have, we're spending twice as much as most of the countries in the world, and sometimes as much as 3 times as much. All right. So the government is saying, what we're going to do is watch everybody, and then we're going to take this box, this big black box of services that are being delivered by hundreds of different kinds of people, and we're going to squeeze it. And what's going to run out of it is everybody that can't do things efficiently, economically, and with good outcomes. All right. Now, the unfortunate part of that strategy is that there's no basis for implementation. Now, all of you in this business know that the system as it's set up, where people are compensated for what they do on a piecemeal basis, where most of the people do not have access to funding for healthcare and do not have adequate income and resources and savings to pay for it otherwise, and that there's really no public financing of that, it means that you as providers being held accountable for a system that is unable to perform at its core, in its nature, in its present situation. They simply didn't listen to the Buddha, who said, the first thing we have to do is deal with the world like it is. We have to see it as it is. And we have to have the right purpose. We have to have the right intention. So when that's the case, you must find a way to restructure this whole system from the bottom up. So this conference is the first attempt to do it that way. We're not taking anything off of anybody else's table. There are no models. There are no models out there to do what we're doing. As far as I know, somebody may, other than me talking today, have some idea that there is a model. But I've been doing this now since 1975, and I haven't found anything any different today that we're trying to do to solve this problem than we were doing in 1975. Because we had the HMO Act in 1972, and we were trying to do exactly the same thing that we're trying to do today in 1972. So I haven't seen any changes, and the death rate is still the same and increasing. So we got to shake loose all of the things that we thought were right, all of the experience that we've had in the past, and say, this is a new game, and we got to think about it in a very unique and simple and understandable way so that it can be done. Now, I've only got one artifact to leave with you in this, and I hope it's helpful. I have claims experience dealing with commercial insurance and with HMOs and with Medicare Advantage plans that go back 15 years. And I had actuarial analysis of these, and the accountants that produced the numbers on it were auditing the accounts of these major insurance companies, from which I drew this data. It was drawn on a population that varied from 5,000 or 6,000 to 10,000 or 15,000 people. So it was a big enough population that the data is good as benchmark data. But benchmark data is just that. It's just a way of saying how much it costs to do a particular thing at a particular time in the past in a particular category. And so in your booklets, you'll see a chart. And it's a 11 by 17 chart. That fold out. And what you see here is every category of expense that I saw, then separated by age category, from children 0 to 17, adults 18 to 44, 45 to 64, and people age 65 or older. And then you see what the cost of taking care of each person in each one of those expense categories, all medical categories, all administrative medical categories, all margins, all the actuarial assumptions about reserves and things like that are there. All right. So now we have a picture of what the past has been, and that's where you get your $8,000 a year in cost. This particular experience was better than the $8,000 because it was done within a managed care environment, meaning HMOs were being paid a profit for doing it for less than $8,000 per year per person. So there you will see that this comes out to be somewhere between 20 and 25% less than the usual expense that most everybody else has. All right. But it is still too fat. We will not know whether any of this is true and needed until you take every one of these categories and unpack them in detail. You find out exactly what the allergist is doing and why they're seeing patients and how many they're seeing and what they're doing when they see them and what their medical outcomes are. And then when you get through doing that, you will find out, are we paying too much or too little for allergists? Then you go to the next category and you do the same thing and you unpack that. And when you've unpacked everything and you've looked at all of it and you've discovered what everybody is doing and what their motives for doing it are, then you will know whether it's possible to improve the system and whether you can quit killing people, quit making people sick, and whether you can do it for less money. Effectively, the triple aim that the government has announced that they want you to achieve. That's what the AAA is.
You have 1 minute.
And I am going to wind up because I only have 1 minute. That's what he said, and that's all that I had to say. And so what I'm going to do is allow everybody to come up and put their 10 minutes and their 10 cents, my 10 cents is in, and we'll start the right and go around, except I'm going to leave Henry for last because Henry is doing a survey of what we're doing because that's Henry's work in life. He does surveys, marketing analysis, and all kinds of really smart things. And so when we all get to talk, then Henry's going to be able to talk. And he's got a 10-minute presentation too, already thought. He may change his presentation a little bit. So I introduce you to Fred Trotter, who has a unique experience that you've probably read a little bit about.
So if you don't mind.